The next speaker I call for is Dr. Rakhi Datta.
Good afternoon, everyone. Ultrasound guided bilateral brachial plexus blocks. It's by me, Dr. Rakhi Datta from same institute, Ganga Hospital, Coimbatore. Almost 4,000 blocks per year, bilateral brachial plexus blocks per year. Ample ultrasound usage, excellent experience, true determination has led us to further one step ahead to go for ultrasound guided bilateral brachial plexus block. These were all the number of patients which we did. There are 9, I've done 10. The first case we had not thought of that time for the study. The thought to begin with this study was bilateral brachial plexus blocks are rare because they are more time consuming, the more amount of drug is needed, more chances of complications. So is general anesthesia the only option? And what if the patient, we can't give general anesthesia or we want to avoid general anesthesia? Like this one who is having a maxillofacial trauma. This patient had a left elbow dislocation. He had a right radius open injury. This was to be done on the emergency basis and the patient was not NBM. This was the another patient who was a seropositive. He was on AKT and ART and he had a recent history of pneumonia. So behind this, the ideas of ideation were that do we give bilateral supraclavicular blocks, which was no, which was bilateral infraclavicular blocks, which was no. So we came on to one-sided supraclavicular block and the other-sided axillary blocks, or the bilateral axillary blocks. And the eureka in this was the ultrasound machine. The aim was to have a site-specific surgical anesthesia, decrease dependency on general anesthesia, rapid discharge of the satisfied patient, avoid complications which are dreaded one, which we are really afraid regarding the bilateral blocks, and of course the quality of pain relief that you can never ever achieve with a single systemic drug, their combinations, or a so-called multiple approach. So in the pre-operative room, after the informed consent, oxygen supply checking, working suction, emergency drugs, intravenous line was either taken on the leg or it was put in the EJV and the monitors were attached. This case series consists of 10 cases, all bilateral upper limb surgeries, on which one side was supraclavicular, on other side axillary or bilateral axillary. The position of the patient and for the supraclavicular block was like this, with the pillow just behind the shoulders and the neck turned to one side. This was where the probe was kept. And the opposite side you can see this was a position with the abducted hand for the axillary and this was a position for the probe. Supraclavicular block, and there's the sonocyte showing the image. This was the first rib, the artery, the plexus. Axillary block, that was a humerus, artery, plexus surrounding, the needle in the in-plane technique, and the musculocutaneous nerve. This was the drugs which were used in our study, that was 0.5% bupivacaine, 2% xaloadrenaline. The 0.5% bupivacaine was 20 ml and 2% xaloadrenaline was 10 ml, and you can see the toxic doses we have not exceeded at all. To this was added a 10 ml of distilled water, and on each side 20 ml drug was introduced. The patient was adequately monitored throughout the surgery. Time in which the block was given was less than 5 minutes for almost all, just for one, because that was a pediatric case we did and it was a 10-year-old girl. Onset of motor blockade was almost instantaneous for the supraclavicular block, while for the axillary block on the other side it took 2 to 5 minutes for the motor blockade. The need of GA was none. We did not require any drug supplementations also for these patients. Complication, which we are actually afraid of, And these are the three dreaded complications. First we can go with respiratory distress, which was no. Local anesthesia or systemic toxicity, no. And pneumothorax, no. All patients had an excellent post-operative analgesia with a VAS score of 0 to 2, and we did not keep them NPO post-operatively. So with that, we propose that with the ultrasound guidance, bilateral brachial plexus blocks are no longer unsafe. They are easier to perform with ultrasound. They can reduce the attempts of needle insertions, and also while if you are giving by stimuplex, already the patient is having some kind of injury and then you are stimulating. And reduced drug volume, that reduces your fear of systemic toxicity. These were my references, and this is my tribute to the pioneer of blocks in Ganga Hospital, a true legend, Dr. Ravindra Bhatt. Sir did this bilateral brachial plexus, brachial blocks in 2008 without any gadgets. It was done only with paresthesia, pure paresthesia, but it was superbly time-bound, with one block on one side 1 hour prior, and after that, after 1 hour on the other side. It was 100% success rate with no complications. Thank you.
This is only 9 or 10 patients that you have done.
Actually, ma'am,
And
yes.
have you done any since you completed the study? Or was this a specific?
Ma'am, actually when we came out with it, we have just started, so we got 10 patients. We did 5-7 more recently in this 2 months, but as we are done with this case series and we have already monitored this patient, we stuck to this 10 patients only because they were adequately monitored. As in our hospital, actually each and every consultant may have done 2 or 3 bilateral brachial blocks, but we didn't take that cases because they were done by other anesthetists. It was not done by me, so I couldn't monitor the patients. So these were actually 10 cases which me and Dr. Manikandan sir, we did it together.
How long did the analgesia last? For single shot blocks, I don't expect it to be beyond 24 hours.
Yes.
How long did
Ma'am, in this cases, because we didn't have, it was a simple block, no additives, the block lasted for around, we can say averagely between 15 to 18 hours, analgesia. But we do give another kind of paracetamol or something else also is started for the patient. It's like we give block and nothing else is added. It's not like that. Something else is also going on to the patients. But yes, intraoperatively, we didn't have to give any opioids or anything. It was just midazolam which was given for them to sleep. That's it, ma'am.
Was it the same with the patient with the facial-maxillary injury too?
No.
Required something more.
Yes, yes. Of course, ma'am. For the facial-maxillary surgery, we had to give him fentanyl a slight more compared to others. And actually, I would like to add that we did one more case of pediatric, as I mentioned. That was a pediatric case, and of course the dose was not this much. The concentration was less in her. On the supraclavicular side, we gave her only 6 ml of the drug, and the axillary side we gave her 10 ml of the drug. Total surgery was done with a 15 ml drug for her.
Thank you.
Thank you, ma'am.
Thank you for the wonderful work and the presentation, but I would like you to think a bit more about your conclusion, because based on 10 patients, I don't think
Yes.
your conclusion suggested safety. I don't want
Yes,
the
yes.
audience to go home and believe that everybody can reproduce your result, and also the NPO's the status. Not if someone is not able to get a 100% success rate, what would you
Yes.
do when they need a general anesthetic?
Sir, if presently we have done with only 10 cases, I think next time when I meet you, maybe I have done 100 cases, but today I have done only 10 cases. And with success rate, yes, with 10 cases, I can seriously say, with a true heart, it was 100%. But yes, we need to do more surgeries with it.
I just want all of you to remember that there is no such thing as 100% success. So please be moderate when
Yes.
you make your presentation.
Okay.
Thank you.
Thank you.